All right, welcome everybody. Thank you for coming to a special CFAR seminar series at a new time. The CFAR seminar series is, if you're new to this, the seminar series is an opportunity for HIV and AIDS investigators to share their research in a cross-disciplinary platform for fostering collaborations. So today we have two speakers. We have a New Faces seminar that precedes our CFAR seminar. So our New Faces speaker is Dr. Jane Lee. Dr. Lee is an assistant professor in the School of Social Work at the University of Washington. Her research focuses on reducing health disparities among racial and ethnic minority immigrant populations and explores questions on how and why migration-related processes affect communities unequally. Dr. Lee, we're looking forward to your talk. Thank you for making this time.
Of course, thank you. Share my screen. So, good morning, everyone. It's wonderful to be here today to present some of my work focused on health communication, specifically among linguistically diverse Latino sexual minority men in relation to PrEP uptake. So, as mentioned, my name is Jane Lee. I'm an assistant professor in the School of Social Work, and I've been a member of CFAR since I joined the UW, and I'll just note that I've benefited so greatly from the junior investigator group through the behavioral sciences core here at the CFAR, and much of the work that I'll be presenting today has really been the result of amazing mentorship and guidance from CFAR investigators and just all the support that I've received through the CFAR. So really grateful to be here today. So in brief, I'll be discussing some of my more recent work that has centered around health communications, specifically in relation to HIV prevention. And I'll be focusing this work on Latino, gay, bisexual, and other sexual minority men, and highlight some potential opportunities to apply health communication strategies to address disparities in HIV prevention, particularly PrEP uptake among Latino sexual minority men. And I'll be providing some preliminary results and analyses that I'm conducting using the American Men's Internet Survey led by Dr. Travis Sanchez at Emory University. And then I'll provide some implications for HIV prevention and some strategies to increase PrEP uptake. So as many of you, I'm sure, are aware, disparities in HIV, including diagnoses and access to prevention strategies, continue to persist among racial and ethnic minority groups in the US. So in the United States, Hispanic and Latino individuals are disproportionately affected by HIV. They account for approximately 29% of all new HIV diagnoses, while comprising about 19% of the country's population. And among sexual minority men, the group who are the most affected by HIV in the US, about a third of all new diagnoses among sexual minority men were among Latino individuals. So, despite these data and despite higher rates of HIV diagnoses among Latino sexual minority men, they continue to experience poor outcomes across the HIV prevention care continuum, including PrEP uptake and adherence. So we know that these disparities are the result of various social determinants of health, and these social determinants pose significant barriers to accessing health services among Latino sexual minority men. Some of those barriers being immigration status, socioeconomic status, stigma, racism, education, and language. And while we know that these barriers are complex and that they intersect and that there are also other social determinants to consider, language is a particularly important factor in our ability to obtain important information, as well as process and exchange information and services related to health and HIV. And with regard to language, we know that in the US, there are a significant number of individuals who report being limited English proficient or not being able to speak English well. So they account for about 8% of the country's population. And Spanish is the most spoken non-English language in the US, right? In the US, about 42% of all immigrants report speaking Spanish at home. So on a personal level, I've always been interested in the role of language in health, just from being from an immigrant family and growing up in a household where English wasn't our first language. But I began to think a bit more critically about language in the context of health communication when I worked on a research project to develop a social media campaign to improve engagement in HIV prevention services among Latino immigrant sexual minority men. So in brief, I was working with Entre Hermanos, which is an amazing community-based organization in Seattle that provides HIV prevention services in a culturally appropriate way for the Latino community. And in our work, they wanted to explore the use of social media applications to really raise awareness about HIV prevention strategies, such as HIV testing and PrEP use, particularly for Latino immigrant sexual minority men, and particularly for those who might have limited English language skills. So this was truly a community-based study, and we started by conducting some interviews and focus groups to first assess the feasibility of using a social media campaign to engage Latino immigrants in HIV prevention, as well as explore the content that might align with behavioral determinants of seeking HIV prevention services among Latino immigrant sexual minority men. And I won't go into all of the details of this study, as I've presented parts of this study before, but during the interviews with this community, the mention of this chill pill campaign came up as an important theme during discussions about the types of images and content that participants thought would really influence their likelihood of engaging in HIV prevention behaviors. So what you see are the images that were used as part of the campaign. And while I'm not affiliated with this campaign or know too much about how it was developed, what I do know is what study participants mentioned about it. And you can see on the left is the English version of the campaign, which used the slogan "Chill Pill," and on the right is the Spanish version, seemingly designed for the Latino community. And, study participants actually continue to bring up this campaign to really note that they felt that it didn't translate for them. They thought that the message was telling them to calm down and that it was speaking to some negative stereotypes about the community. And in these discussions, it became really apparent that simply translating words into another language is really inadequate for communication or for relaying information about HIV prevention. So, while we know this, there remains multiple questions about how, when, and for whom HIV-related health communication can really be most impactful. And oftentimes, our health communication efforts have really tended to focus on those who speak the dominant language of English without adequate attention to the nuances and the nuanced context in which communication occurs for those whose primary language isn't English. And that's what has launched my interest in health communication strategies. And this is actually an image that was developed from our social media campaign that resulted from those interviews and focus groups that I mentioned. And we're actually currently evaluating this campaign as part of an EHE-funded supplement grant with Entre Hermanos. And I just show this to really highlight how different the images and language that resulted were when we really took the context and perspectives of community members, specifically Spanish-speaking Latino immigrant sexual minority men, into account. And they really talked about wanting images that really empowered them, that were positive and relayed positive messaging about HIV prevention in the community. So in my current work, I'm really taking what I've learned from this previous work and from my collaboration with Entre Hermanos and drawing upon communication infrastructure theory, or CIT, which developed as a social ecological perspective to demonstrate how the communication infrastructure within a community can shape social and health outcomes. And I'm thankful to be working with an expert in communication, Dr. Carmen Gonzalez from the UW Department of Communication, whose work has really focused on health communication, specifically communication infrastructure theory. And as you can see in this model, the communication infrastructure really encompasses key storytellers. And so these key storytellers can be at the macro level and can comprise, national and international organizations. And then there are storytellers at the meso level, which can encompass community-based media or community-based organizations. And then storytellers at the micro or individual level who are just individuals who you might communicate with, such as doctors or family or friends. And there are these multiple levels, and all of these storytellers comprise the storytelling network that has the capacity to really tell stories about a community and the communication environment. And then these key storytellers are enabled or constrained by the communication action context, which encompasses the social and community characteristics that can affect the availability and accessibility of communication resources, as shown in this figure. So you can really see how the storytelling network is embedded in this communication action context. So for example, if you reside in an area with limited access to the internet or technology because you might live in a rural community, that can constrain opportunities to share or obtain information online. And perhaps, living in an area with a large number of public parks or facilities that might enable opportunities to converse with your neighbors or family members or friends. And really what this model highlights is that the storytelling network is and can be the primary connection to important information that can shape behaviors. And applications of CIT have really demonstrated that the storytelling network and communication action contexts are associated with a range of health behaviors, such as, health information seeking and knowledge of disease prevention. But there's really been limited work on CIT in relation to HIV prevention, and very few studies that I've found that have really focused on the communication infrastructure of Spanish-speaking Latino communities, and that really sparked my interest in examining this a bit further. So the theory being that perhaps by better understanding the communication infrastructure of Spanish-speaking sexual minority men, those storytellers or the storytelling network and communication action context can influence the factors that we know shape HIV prevention behaviors, such as PrEP use. So specifically, I was thinking about the IMB model. We know that having access to resources, information, being motivated to use PrEP or get tested for HIV, and having the behavioral skills to engage in those behaviors can influence actual uptake of PrEP or HIV testing behaviors. So I wanted to better link the communication infrastructure of Latino Spanish-speaking sexual minority men with these HIV prevention outcomes. So I wanted to really recognize that while the communication infrastructure might be similar for some communities, regardless of, their primary language, really thinking about how they can be different in important ways depending on one's primary language. And rather than just focus on understanding the communication infrastructure in general, or for those who speak English, I wanted to pay close attention to the storytellers and networks of Spanish-speaking or Spanish-dominant Latino sexual minority men. And this really kind of draws from a prior study that I conducted with colleagues where we used data from the Understanding New Infections Through Targeted Epidemiology, or UNITE cohort study, and the Washington HIV/STI Prevention Project, where we examined differences in HIV-related prevention and risk behaviors. And we observed some important differences between the Spanish-speaking group and the English-speaking group. So specifically, we looked at those who completed surveys in Spanish compared to those in English. And it really showed that there might be, a distinct health and risk behavioral profile among the Spanish-speaking group compared to the English-speaking group. And this really suggested the need to further examine these behaviors with attention to linguistic diversity and really focusing on language and what that means a bit further. So currently, I'm seeking to assess how the storytellers within the storytelling networks of Spanish-speaking Latino sexual minority men differs from that of English-dominant Latino sexual minority men, with attention to their communication action context, or the communities in which the communication occurs, and to really assess how they're linked to HIV prevention outcomes such as PrEP use, with the goal being that perhaps with this information, we can inform health communication approaches to really improve PrEP uptake and HIV prevention behaviors among linguistically diverse sexual minority men. So I'm currently using data from the American Men's Internet Survey, AMIS data. Many of you might be familiar with that data set. It's led by Dr. Travis Sanchez at Emory University, as I mentioned, and it's a national cross-sectional web-based survey of US sexual minority men, and they conduct the survey each year with the goal of surveying about 10,000 participants each year. And in 2021, with support from some of my colleagues, Dr. David Katz and Dr. Roxanne Karani and myself, we were able to launch a Spanish version of the survey. So we were able to conduct the survey with those whose primary language was Spanish. So that provided an opportunity to really look at this potential language issue. And so overall, participants are at least 15 years of age. They reside in the US. And for our current analyses, I focused on those who reported being HIV negative or were unaware of their HIV status, and focused on those who identified as Hispanic or Latino. And the AMIS survey collects sociodemographic characteristics, as well as a range of sexual behaviors, substance use behaviors, and HIV prevention behaviors, as well as some other social measures. And so in thinking about communication infrastructure theory, I wanted to apply CIT and assess the characteristics of participants' communication action context, as well as their individual level and meso-level storytellers. So through the survey, we assessed the communication action context by looking at participants' census region, so whether they resided in the Northeast, the Midwest, South, or West. We also looked at the urbanicity of where they lived, so the urban-rural classification of participants, so whether they lived in a large metro area, medium metro area, small metro area, or a micropolitan area. And to assess individual level storytellers, we assessed this using a measure that asked about who participants have disclosed their sexual orientation to. So the assumption being with this measure is that if they've told these individuals about their sexual orientation, these individuals might comprise the potential storytellers in their network. And if these individuals haven't disclosed this information, perhaps it's because they aren't members of their individual level storytelling network. So this question was asked about gay, lesbian, or bisexual friends, friends who are not gay, lesbian, or bisexual, family members, healthcare providers, employers, and fellow employees. And then at the meso level, storytellers were assessed through a question that asked about participants' engagement in organizations or activities. So the assumption being with this meso-level storyteller aspect that if they are part of these organizations, then perhaps these organizations comprise the meso-level storytellers that could potentially communicate to participants about health and HIV-related information. And so those meso-level storytellers included church or religious groups, clubs such as sports or student groups, cultural activities, and activities in the community. And for our outcomes, we were interested in PrEP-related outcomes such as PrEP awareness, having discussed PrEP with a healthcare provider, current PrEP use, and whether they were aware about long-acting injectable PrEP. So we used a three model kind of stepwise approach to our analyses, where we first assessed the association between PrEP outcomes and the individual level storytellers. And then we added the meso level storytellers to the model, and then finally added the communication action context measures into the model, all controlling for sociodemographic characteristics. And we conducted separate models for the Latino sexual minority men whose primary language was Spanish, and a separate model for those whose primary language was English, to really assess whether there were different storytellers that might be salient for the Spanish speaking group compared to the English speaking group. And so for some preliminary results in our analyses, we saw that participants who reported Spanish as their primary language tended to be older. They reported lower incomes, had lower education levels, and were less likely to have health insurance, and were also less likely to have been born in the US. So these data are similar to prior studies that we've seen, in that these groups do differ across important sociodemographic characteristics. And for the sake of time, I wanted to just focus my results on the PrEP use outcomes among participants. And in these analyses, we saw that for the Spanish-speaking group, the non-gay, lesbian, and bisexual friends emerged as important individual level storytellers, while for the English-speaking group, doctors emerged as salient storytellers. And also for the English-speaking group, church religious group at the meso level were influential storytellers, with those involved in church reporting lower odds of PrEP use than those who weren't involved. And of course, the urbanicity of where Spanish-speaking Latino sexual minority men resided was also associated with PrEP use. And I'll just note that there were some similar nuances that emerged across the different PrEP outcomes that we assessed, such as the PrEP awareness, the awareness of long-acting injectable PrEP, with certain storytellers emerging as important for the Spanish-speaking group and not necessarily for the English-speaking group. So this really points to potential differences in storytellers and suggests that we need to better understand why and how these storytellers might be shaping these outcomes. So really interesting that, you know, the storytellers that might influence PrEP outcomes are distinct for those who speak Spanish, and, you know, not necessarily just assuming that groups are getting the same information from the same individuals, or thinking that by relaying information on certain news or websites that it's going to reach the same population, because not only the storytellers might be distinct, but the context in which these storytellers are communicating can really matter for shaping the determinants of HIV prevention outcomes for this community. So really, the objective of this work is to not only identify the salient storytelling networks that are linked to PrEP outcomes, but to also understand how they're relaying this information within different communication action contexts of Latino sexual minority men. So the next steps of this work are to qualitatively explore the constructs and outcomes and to assess how these storytellers might be influencing PrEP-related outcomes in the community. And we're going to do some qualitative work to also think about other storytellers that might have not been captured in this quantitative analysis, and to think about other ways that people might be getting their information and might be obtaining their stories about their community. And with those information, we really hope that by identifying these storytelling networks and characteristics of the communication action context, that we can begin to inform the development of strategies to really optimize health communication approaches, specifically for Spanish-speaking sexual minority men, to enhance engagement in HIV prevention services for a group that really has been marginalized and overlooked in terms of how to really communicate information appropriately for this group. So overall, this work really presents an opportunity to strengthen health communication capacity and to really think about how communication interventions can empower groups to engage in prevention behaviors. And I really hope that this work allows my research, as well as others, to think more critically and holistically about health communication and its critical role in shaping HIV prevention outcomes and the disparities that we see in the HIV epidemic, rather than just thinking of language as just another variable to consider, but to really think about it and examine it further and think about how we can harness the opportunity that it presents for health communication. So I want to thank you. I want to acknowledge Entre Hermanos, which is an amazing community-based organization that I work with that I mentioned, the AMIS survey, and the folks at Emory University who work with AMIS. And I want to acknowledge Doctors Susan Graham and Roberto Orellana, who are the mentors on my New Investigator Award funded through the CFAR that has supported a lot of the work that I presented today. And a special thank you to colleagues who I've been collaborating with on a lot of this work, Roxanne Karani, David Katz, and Dr. Carmen Gonzalez. So thank you.
Thank you so much, Dr. Lee. That was a great talk. If folks have questions, you can either put them in the Q&A or you can raise your hand and we can unmute you. If there are no questions, I had one. I was curious about social media interaction and consumption and whether it was different across Latino, your Latino speaking group or Spanish speaking group compared to not.
Yeah, so in that preliminary work, so in the data analysis, we weren't able to assess the social media aspect, but in our work with developing the social media campaign, we spoke primarily to Spanish-speaking Latino sexual minority men, and they did discuss how they use some of the applications a little bit differently and are interacting in different ways. And in developing the content that we're currently evaluating as part of the other study, they talked about how it's important to not only have language and terms that are appropriate for them that might not necessarily resonate with groups who don't speak Spanish as their primary language. So really integrating that in the development of specific messages is really important. And that's what we want to harness through this work. So yeah.
Thank you so much. There is a question from Dr. Simoni.
Yeah, can you hear me?
Yes.
Yep.
Jane, great job. I had a question. I know you've talked with Michelle Andrasik, I'm sure, about this when she had a campaign for African-American men in Seattle. And it was interesting. It was great. It was very focused and, quote, targeted at African-American men. But there was an unintended consequence in this city, majority white city, that a lot of people thought, I think both the African-Americans responding, especially thought this might have stigmatized them because all the ads were about sexual behavior and HIV. And you'd go into a bar and there'd be basically catering to white men, yet there'd be a poster about an African-American man and HIV and, the importance of, safer sexual practices So I just wanted to get, and Michelle speaks openly about that, and it was just a great learning experience about it. But I just wanted your comments on that.
Yeah, I mean, that was something that did come up in our interviews and focus groups in that previous study, where they did mention those other campaigns, and they thought, oh, this when we see images that are specifically having this information, it can further stigmatize us and make it seem as though, you know, we're the ones that are engaging in those behaviors. And it's important that these messages are relayed in a way where it's important for everyone to engage in HIV prevention behaviors and to have access to information. And so we're really cognizant of that. And I think we were thoughtful about thinking about where these images are being presented as well as how, and thinking about imagery and messages that aren't necessarily suggesting that there is we should be excluding one group and really focusing on them, but showing that this is important for everyone, as well as the group that we might want to encourage to have this information so that they can get linked to services. But that is a great point. And oftentimes we think that, we need to get this information to them without thinking about how it might be affecting the other groups. So I think that is a discussion that we should continue to have. And it was mentioned in our discussions, and we were thoughtful about how the images that we create don't necessarily contribute to that. So I think that's a great point.
Thank you.
Thank you so much. I'm going to hand it over to Dr. Connie Kellum, who's going to introduce the next speaker.
Great.
Thank you so much for joining.
Thank you, Pavitra, and thank you, Jane. That was really interesting. I learned a lot. And it is now my pleasure to introduce my close colleague, Dr. Sinead Delany-Moretlwe, who I believe, Sinead, if I'm not wrong, that we have been working together for 20 years, which makes me feel quite old. But it was my pleasure when we started doing herpes suppression trials in Africa. And just to be fully transparent, I had never been to Africa when we started embarking on these multi-center trials, that Sinead took me under her young wing, I should say, at that time, and taught me so much about, like, how do you take a concept and actually make it happen? How do you, we both had a lot of interest in herpes, and I had a lot to learn about how do you actually do HIV prevention trials in downtown Johannesburg and a lot of different settings. And Sinead was really, really instrumental. It's been my pleasure to work with her in the 20 years since. So we'll now hear from Sinead, who is going to talk to us about cabotegravir moving from efficacy to implementation. Sinead was, still is, I guess, the co-chair or the chair of the HBTN 084 study on injectable cabotegravir for HIV prevention. She's the director of research at the Wits Reproductive Health and HIV Institute, and is a professor at University of Witwatersrand. So thank you so much, Sinead, for joining us for this talk. And I know there's a lot of interest and in what you have to share. So thank you.
Thanks so much for the introduction, Connie, and for reminding me how much we've aged, but I think we've done it gracefully, and I look forward to the next 20 years of collaboration. I'm just going to pull up my
Sinead,
slides.
I will be like frail by that point.
So I'm hoping you can now see everything in presentation view. And I'm going to talk to you about long-acting injectable cabotegravir from efficacy to implementation. And I really appreciate the invitation, but also kind of the chance to talk about something that I've been involved in for the last few years. And really, I think we're at an incredibly exciting phase. And it's been really interesting to, I think, look back on what we've learned over the past 5 to 7 years. So I think it's useful to remind ourselves about the problem that we're trying to solve. And in sub-Saharan Africa, women and girls bear a disproportionate burden of HIV. About 25% of new HIV infections occur in women and girls aged 15 to 24, but they represent only 10% of the population. And so it was incredibly important when PrEP was recommended by the WHO, particularly for for use in countries in sub-Saharan Africa. And since that initial recommendation, we've really seen an increase in the number of PrEP initiations, such that toward the end of last year, about 3.3 million people had initiated PrEP. We've also seen a lot of updated guidelines come out that really focus on sort of optimizing PrEP delivery to populations that live in resource-constrained settings. And I think it's particularly heartening to see that many of the initiations are in fact occurring in sub-Saharan Africa, and that South Africa and Kenya actually are in the top 3 countries with respect to PrEP initiations. We also have population level data now from the African region that really sort of endorses the idea that PrEP can reduce HIV incidence at a population level. So really strong evidence of the potential for PrEP to change the trajectory of the HIV epidemic in our region. And so I think it's, it's in that context that we sort of reflect on the challenge that currently faces us, that there are, despite the PrEP initiations, there are many young women in particular who struggle to persist with PrEP for a variety of reasons. And this is persistence data from a study that Connie led and that we were involved in. And I think it's very sobering that we know that young women recognize their risk, they want to use PrEP, but they experience a number of barriers to continuing PrEP. And those barriers can probably be related to the drug itself in terms of side effects or pill size, but also to the health system in terms of the costs associated with travel to clinics, issues with access at clinics in terms both of being offered PrEP, but also potential stockouts or sort of poor coverage in certain areas with PrEP. The requirements to kind of attend clinics repeatedly when in fact they're healthy. And then there are a number of social barriers, which include the stigma associated with taking an antiretroviral, discrimination against young women who are perceived to be sexually promiscuous, the real threats of gender-based violence and kind of concerns about partner responses to PrEP use, as well as other issues that have been reported in the literature. And in the last few years, we've had to deal with the COVID pandemic and its impact on health services more generally in sub-Saharan Africa. So, kind of the question is, if taking a pill a day is challenging, what would women want in the way of a PrEP agent? And this is work that we did in South Africa a few years ago using a discrete choice experiment. And what you can see is across all population groups, there was a preference for injectable. And that preference may in part be driven particularly in women because of widespread use and familiarity with injections for contraception. From the data from the HPTN 076 study, which was a study of rilpivirine as a potential PrEP agent, I think sort of reinforces the idea that, or helps with the idea that even though DCEs are talking about sort of hypothetical preferences, when people actually use these agents with experience and time, their preferences strengthen. So we don't just have data for hypothetical preference, but also experience. So one of the potential agents for an injectable PrEP is cabotegravir. It's an integrase inhibitor. It's an analog of dolutegravir, but it's not exactly the same. And I'm no chemist, but it's amazing what some hydrogen bonds can do to change a drug. The importance of cabotegravir really is that it has a high barrier to resistance. And because of its pharmacokinetic profile, it allowed for 1 to 3 months dosing when it's nanomilled and then suspended in a formulation which can be injected as a depot. The initial data had suggested from treatment studies that it was a potent antiviral, anti-HIV drug, and data from non-human primate studies really supported the potential for efficacy as PrEP. So cabotegravir was intended to be delivered both for treatment, but also for prevention. And a number of studies were planned, initial phase 2 studies and subsequently 2 large phase 3 trials. And the phase 2 PrEP studies really provided data on the final dose that was used in the phase 3 studies, which is 600 milligrams injection every 8 weeks. So here is a schematic of the study design, and the reason that I put it up is that it often prompts a lot of questions about how much of the design is actually relevant to programs. So at the time we did the study, we had very few data on cabotegravir for PrEP, and we didn't know about efficacy or safety. So out of an abundance of caution, the study was designed with a 5-week oral lead-in phase with oral cabotegravir, and then participants transitioned to the injection phase, and that consisted of 2 injections 4 weeks apart, which were a loading dose followed by 8 weekly injections. And anyone who stopped cabotegravir prematurely was offered open-label Truvada, and that was to cover the pharmacokinetic tail. Cabotegravir is long-acting and therefore has a long tail. And there was a theoretical concern that people who acquired HIV infection during the tail phase and who had emergent infection might develop resistant infection in the context of sort of CAB monotherapy, albeit those levels were declining. So that was really the rationale for the study design. And then HIV and pregnancy testing were done at each of the visits, and particularly prior to product administration. And all participants in the trial received real-world counseling, which was aligned with national guidance for adherence support in the sub-Saharan African region. So you may or may not recall, but in 2020, both trials were stopped prematurely for efficacy, and the DSMB recommended that they be unblinded. The HPTN-083 trial was a trial for cisgender men who have sex with men and transgender women. It enrolled just over 4,500 participants in countries in North and Latin America, as well as South Africa, Thailand, and Vietnam. And they were the first study to be unblinded. And what they showed was that HIV incidence was 66% lower in individuals who'd received CAB compared to those who'd received TDF-FTC. In November of the same year, the HPTN-084 study that had enrolled 3,224 participants at 20 sites in 7 countries was also unblinded. And there we saw that people in the cabotegravir arm had an 88% lower risk of HIV infection compared to those in the CAB, in the TDF-FTC arm. And the overall conclusion was that CAB was generally safe and well tolerated, and in addition to being effective as PrEP, it was likely that effectiveness was because of the adherence advantage that it conferred. So here is data from 084 that really is just aimed at demonstrating that we didn't test for TDF-FTC levels in all participants, but we had an adherence data set that was monitored, and that data was available to the DSMB, but not available to any of the study team. And what you can see is that despite significant efforts to persist on TDF-FTC, by within a year, only a third of women had detectable levels that are consistent with HIV protection. And I recognize that these are plasma levels, but sort of the same results have been seen with the DBS. By contrast, injections are directly observed, and what we saw in terms of injection coverage was that sort of in excess of 95% of visits were covered by injections, demonstrating the potential for an adherence advantage with injections. So there has been additional work, or there was a qualitative sub-study nested within HPTN 084. And what we've learned from that, that was data from 63 participants in 4 of the sites in HPTN. The majority of those participants are single. Importantly, 20% identified as sex workers, and there has been some commentary that not, kind of insufficient work has been done with sex workers, but many of the participants in 084 were sex workers and identified as such. And what the message that we heard from them is that the participants liked a discreet and convenient PrEP method. And this was particularly in the context where they had busy lives and felt that they were not able to adhere to daily pills. So in endorsing the hypothesis we had that women would prefer a more convenient PrEP method. Another key message that's emerged over the last year or so is that the protective effect of CAB is sustained over time. Our study was unblinded in the first 2 years really of implementation. And there was a period where people remained unblinded, but still allocated to their primary randomization arm prior to us implementing an open label extension. And during that period, we continued to monitor HIV incidence. And what you can see is even with additional accumulation of person years and infections, the risk reduction remains very similar to what we saw in the initial unblinding, with an additional 2 infections identified in the CAB arm, more in the Truvada arm, and a risk reduction of 89%. So some people are interested in the cabotegravir injections, the cabotegravir infections. We are very fortunate to have very few data points in HPTN 084. More infections have been observed in HPTN 083. We have used a categorization system really based on when people acquired infection relative to their drug exposure, particularly their injection exposure. And what you can see in this graphic is that if I take you through the different rows, in the A case is someone who had infection prior to enrollment. There are a number of B cases, and these B cases are defined as people who had no recent CAB exposure and none of them had received injections. We had one C case, which was someone who acquired infection during the oral lead-in, and I think emphasizes the real challenge of people who want to take an injectable having to take oral pills first. And then we've had one participant who had injections. They weren't on-time injections, and she had several injection delays, and at her last injection visit, she had HIV detected after a delay of 16 weeks, and she had CAB concentrations below sort of target thresholds for being considered for protection. One of the lessons that we've learned from this trial is that cabotegravir is highly suppressive and it delays the detection of HIV. Sort of by limiting viral replication, you get delayed development of antibody responses, and this means that our assays are slow to detect infection. In the context of prolonged monotherapy, this can lead to INSTI resistance, and this has been observed in the HPTN 083 study in particular, where they've seen people with on-time injections with breakthrough infections who have had delays in diagnosis and have subsequently developed resistance. Reassuringly, that resistance has been overcome by other non-INSTI regimens, and those people have subsequently virally suppressed. But this really prompted a discussion about the value of adding a sensitive HIV RNA to assay to the screening algorithm. It's actually now part of the FDA recommendation for testing in people who use cabotegravir in the US. It's not a recommendation more widely in other jurisdictions. And it was one of the one of the strategies that was actually added to the open label extensions. So as I mentioned, once the DSMB recommended that the study be unblinded, participants were retained on their they were unblinded, retained for a period on their allocated arm while we developed the open label extension, which could then be reviewed and implemented at sites. The protocol amendment offers the opportunity for all people to access open label cabotegravir. And importantly, it also has allowed for inclusion of the under 18 population who were in 2 sub-studies, 08401 and 08301. Just to give you a teaser that the data on 08401 is going to be presented as a late breaker at CROI. And this is data on the safety and acceptability of injectable cabotegravir in people under the age of 18 and above 35 kilos. The other thing that we did with the open label extension is to drop the oral lead-in. This is because a review of the data in both the treatment and prevention program suggested that there probably wasn't a big enough safety signal to warrant it. As I mentioned, we added HIV RNA testing as part of the testing algorithm, so we now include HIV RNA testing at every visit. And in HPTN 084, we relaxed the contraceptive requirements and offered women the option to consent for active dosing through pregnancy. And I'll talk about that in a bit more detail in a little later. There are also there are a number of other analyses that are going on, which are really aimed at supporting implementation decisions. And one of those is the question about whether we could extend the interval of dosing from 8 to 12 weeks in women. This was originally supported by early POP-PK modeling prior to the trials, and the early phase 2 data had sort of proposed 12 weekly dosing with a higher dose, but we subsequently opted for the 8 weekly dosing to be aligned to the 083 study. Because of COVID, we had some experiences of extended interval dosing, and this data will be presented at CROI. And the reason it's of interest, I think, is many people ask, why don't you have a longer interval that could align with, for example, contraceptive injections like DMPA? So the open label extensions were implemented from the start of last year for HPTN 084. 083 is about 6 months ahead of us. With respect to 084, all sites have been activated. And I can tell you that 80% of participants who were eligible for the open label extension have opted to continue. Those that declined really are people who've relocated or lost to follow-up, or I think what's really important to acknowledge is that some of these people who'd been on study for 5 years have actually had a change in HIV risk and have opted not to enroll. Interestingly, about 3/4 of all participants have accepted cabotegravir for PrEP. The 084 population is a unique population. They probably all had a preference for injections when they joined the study. So it's interesting to see this uptake. We had a regional meeting last week, and we discussed with investigators from the 20 sites what were their experiences of supporting PrEP choice. And they came out very clearly saying that fear of injections was a big decider for people who didn't choose CAB. But there was also a strong preference amongst many women for a discreet, convenient method of PrEP, and that really drove a lot of the choice for CAB. And interestingly, there were populations who had concerns about use of cabotegravir during pregnancy and who wanted to become pregnant, and so who declined cabotegravir, but also people who recognized the effectiveness of cabotegravir and actually had a preference for using cabotegravir during pregnancy because they wanted to be assured that their infants would be safe and HIV-free. I think what's interesting for me is that there was very little discussion about the issues around what I would call reversibility or the long tail. And that's not figuring currently in people's conversations. And it may be something kind of to track going forward. And then I think the other thing in our region that's important is that people are very are always part of social networks. And so partners, family, and others were very influential in people's decisions. So to talk a little bit more about the work around pregnant and breastfeeding women, some of you may recall that there were concerns about the peri-conception use of dolutegravir, the analog drug, in people living with HIV who were pregnant. And that prompted really actions in the 084 trial to require all women to use a long-acting reversible contraceptive, so either a injectable or implant. And we had very low pregnancy incidence during the blinded period of the trial. Here I'm presenting data comparing the blinded period and the unblinded period, which was also about a year, with respect to pregnancy incidence. And what you can see is this virtually 2 to 3-fold increase in pregnancy incidence in the unblinded period. And that signaled to us that women wish to conceive safely without fear of HIV infection. And it's going to be really important as we introduce cabotegravir into regions of higher pregnancy incidence that we have data on the safety and pharmacology of cabotegravir during pregnancy, particularly so that we can guide on whether there is a need for dose adjustments. So there was some preliminary work done from the blinded study, really in addition to tracking pregnancy outcomes, to understand residual CAB concentrations. And what we learned from that work, and this is a population who, once they had a positive pregnancy test, had injections held. So we were really looking at terminal pharmacokinetics of cabotegravir. But what we saw is that cabotegravir concentrations tended to last throughout pregnancy. They were generally well tolerated, and reassuringly in terms of dose, the drug concentrations were comparable in terms of decline to non-pregnant participants. And so on the basis of this data, we moved to modify the protocol. One of the things we did before implementing the change was really to consult with communities. And this was because we were aware of the very sort of negative messages that had been in the community around sort of dolutegravir, neural tube defects, concerns about safety. We had a community consultation in May 2021, and we polled participants. There were about 100 participants from the various sites representing local communities about sort of their attitudes or perceptions to use of cabotegravir in pregnancy. And what you can see is that most supported the relaxation of the contraceptive requirements. More than half thought that participants would actually accept injections during pregnancy. When they were asked about themselves specifically, they were a bit more cautious. And what was interesting is that there was many more who would thought they would accept injections during lactation. And an important finding for us was that there was a real concern that partners would object and could potentially be a barrier. And so this prompted us to do additional work and create additional materials to be used in discussions with pregnant women, but also with other community stakeholders and potentially partners to address concerns that people might have about the use of cabotegravir in pregnancy, and really, I think, to share what's known and what's not known, and to support informed choice on the part of pregnant women. So really, just to outline sort of what we're currently involved with now, participants still undergo pregnancy testing at every visit. If they test positive, they have the option to enroll in the pregnancy and infant sub-study if they've had prior CAB exposure or they want to initiate CAB. And they have options really to use CAB during pregnancy or not. They're followed up monthly. They have injections 8 weekly as per the regular schedule, but we do additional data collection really to measure PK at both trough and 4 weeks post-injection. Their visits are aligned as much as possible with antenatal care visits, and we require early ultrasound to just continue to exclude any concerns about early anomalies. At delivery, there are additional assessments and sample collection of cord blood and breast milk and maternal plasma. And then there is a sampling schedule for the postpartum period, which includes samples from mothers and infants, and follow-up of the infants through to 1 year of age. So we assumed, based on guidance largely from the FDA, that a sample of 50 participants on cabotegravir would be sufficient to answer the questions about dose adjustment, and that we would need a larger sample size to provide data on short-term safety during pregnancy. So to date, we have enrolled 67 participants, 55 are receiving CAB during pregnancy, and we hope to be able to report the PK data later this year. So although we have a very broad label in many countries, I think one of the important considerations is being inclusive of populations at highest risk. And another group at risk for HIV infection are transgender populations, particularly those receiving gender-affirming hormone therapy. So this is data that was presented by the HPTN 083 team, where they reported on a population that included 12% transgender women, and just over half of whom were using gender-affirming hormone therapy. In essence, what you can see is that CAB concentrations were comparable between the groups using gender-affirming hormone therapy and those not, providing some reassuring data for those populations with respect to ongoing CAB use. So just to continue the list of additional activities to support implementation, there is also work to continue to evaluate the performance of the current HIV diagnostic algorithm. Particularly because of concerns that RNA testing may not be feasible in countries in sub-Saharan Africa, to understand what the positive predictive values are for algorithms without RNA screening. There were also data collected on contraceptive concentration, so we are currently testing those samples to evaluate drug-drug interactions with long-acting contraception. And there are some additional laboratory-based studies to evaluate viral load platforms that could support the development of point-of-care assays if needed. One of the important things that we don't know is what the correlates of protection are. So we've based our drug concentration target thresholds on what we know from non-human primate data, but we actually don't know what those thresholds are in humans, and that analysis is complex, but it's going to provide some useful insights. So that's really all the work from the trials, but there is now a period of gearing up to prepare for implementation in countries as approvals come through. And in addition to approvals in the US, we've seen approvals in Australia, Zimbabwe, South Africa, and we think that there are a number of approvals that are imminent in more of the countries in which 084 was conducted. WHO has also released guidance, which will also be important for many countries in terms of supporting the development of national guidelines to support implementation. And this framework that I put up is really a framework that was developed in part to learn the lessons that we had experienced with respect to introduction of oral PrEP in many settings in sub-Saharan Africa, and in a way to anticipate all the areas that would need investment in order to kind of expedite implementation of a new PrEP agent. So it was agent agnostic. And essentially, this framework focuses on activities that need to be implemented to scale up manufacturing and distribution, clinical research, but also thinking about costing and modeling, delivery, and then individual uptake. And I'm going to talk about some of those issues in the subsequent slides. So one of the big flashpoints, I would say, has been around cost and cost effectiveness, pricing and access. It's been an ongoing conversation since we saw the first regulatory approvals. And there have been concerns that prices are really going to limit access despite the incredible effectiveness in both of the studies. And there were two studies that were published last year that really did cost effectiveness analyses that showed that even with the incremental benefits that you get from cabotegravir that they, while they can tolerate a bigger price differential, they can't tolerate an excessive price differential. And here is a slide from my colleagues at HERO, who did an analysis for the South African context, and they had done the PrEP investment case for South Africa more generally. And in the end, their analyses showed that CAB would still be cost effective if it was twice the cost of oral PrEP. And that really means that the cost per injection needs to be sort of between 11 and 20 US dollars per dose. So with that in mind, there have been obvious discussions and pressure on the manufacturer or the developer, ViiV Healthcare, to come forward with a price point. And last year, there was some progress, I think, to move towards a voluntary licensing agreement with the Medicines Patent Pool and ViiV Healthcare. And there have been a number of other activities really to support PrEP introduction, but also to deal with the sort of pricing issues. I think what should be taken as a positive sign, given the challenges of manufacturing generic cabotegravir, is that the price, at least in the scale-up phase, is close to kind of what some of the country sort of estimates for cost effectiveness have been. So one hopes that with some of these additional generic agreements that we will be able to see access, particularly in low and middle income countries. So there are also a number of other implementation considerations really related to the populations that are going to be, who are going to most benefit from PrEP, and that is going to differ region by region. And there are important questions about how to deliver based on the populations. For example, we have very few data on use of injectable cabotegravir in heterosexual men or men in general in sub-Saharan Africa. There are also questions about transgender women who may have buttock implants and what that means for alternative sites of injection. And we have also kind of a need to consider delivery approaches for adolescents who may need additional support, as well as pregnant and breastfeeding women. There are key questions about the models of delivery. Do we add on to existing PrEP programs? And also, given the push to sort of provide differentiated services to demedicalize, how do we do that when you need essentially healthcare providers to offer injections? I think one of the important issues that is going to be something to pay attention to over the next few years is really HIV testing and optimal strategies to minimize the emergence of resistance, but also that are affordable in LMICs. And I think the other thing that I would say we are learning from HPCN 084 is that it's important for clinicians to recognize that there is the potential for both false negative, that is delayed diagnosis, but also the potential for false positive results. And clinicians are really going to have to think or be supported to manage these cases and sort of make decisions about whether or not to initiate therapy in populations at high risk for HIV. And then what I wanted to talk a little bit more about is really something I think that HIV prevention services don't have much experience of, and that's offering product choice. Family planning or contraception has a lot more experience with offering a range of contraceptive choices, and data from that field suggests that when a range of choices are offered, you have greater family planning coverage, and I think we would like the same for HIV prevention. But to date, we really have had one agent and a couple of other options, and even in the context of family planning in resource-constrained settings, choices are often limited. So given all these questions, we need an implementation science agenda. Sorry, before I dive into that, maybe just to kind of highlight to you a new publication that was published early this year addressing the HIV testing question, which I think provides some reassurance. This was modeling done by Andrew Phillips and colleagues, really looking at cabotegravir introduction and a range of parameters or impacts in terms of incidence, prevalence, and importantly in panel C, resistance. So I found this data really interesting. While there was an increase, so without cabotegravir, INSTI resistance is about 2%, and with cabotegravir, it is modeled to rise to as much as 13%. But the overall gains associated with cabotegravir in terms of reductions in HIV incidence and AIDS deaths really means that long-acting cabotegravir PrEP is predicted to be cost-effective if delivered at similar cost to oral PrEP with antibody-based testing, and really isn't likely to kind of lead to substantive INSTI resistance. So some reassurance, I think, for African countries as they decide what testing strategies to use. So there are a number of studies that are poised, implementation studies that are poised to launch in sub-Saharan Africa. The Catalyst study is likely to start in the middle of 2023 this year, and there are a couple of other Gates-funded studies also due to start. Most of them are targeting populations of women in sub-Saharan Africa. And when you look at the sample sizes, the numbers who will receive CAB relative to the need are quite small, but it's going to be really important for the health system to learn how to do this delivery. So as I mentioned earlier, one of the things we don't have experience of in sub-Saharan Africa is offering HIV prevention choice. And one of the potential options is really to use decision support tools. These are used in a range of healthcare settings, and they've been shown to improve client knowledge, values congruent choices, and risk perception. And there is a belief, and Connie and I did work really to develop a PrEP decision support tool, which could overcome some of the barriers to PrEP delivery, particularly in settings like in sub-Saharan Africa, where providers are very busy, they don't have time, they may have limited training, they may have limited skills, particularly early on in product introduction, but also where there are often power disparities between providers and clients. And a decision support tool could help overcome many of those challenges and ensure that people who want PrEP get relevant information that helps them make an informed choice. We developed version 1 of the tool and evaluated it in a randomized controlled trial in Johannesburg, and actually showed, surprisingly, that we had a 2-fold higher rate of PrEP continuation at 1 month. And this was really interesting preliminary initial data, which we hope to expand. But also anticipating the introduction of additional PrEP agents, we updated the tool to include information on the dapivirine ring and cabotegravir, which we hope to evaluate in further studies. So just to give you an idea of the decision support tool, it's framed to be very sex positive and very empowering. It's particularly focused on young women at this point, but there is the potential to develop these tools to be more inclusive. In talking about risk, it provides people with examples, because we've learned that young people don't like to be stigmatized in terms of their risks and their behavior. And importantly, it gives people the options that are available and then allows them to compare them so they can make choices that are going to fit into their lifestyle. And the tool also includes a contraceptive module with the idea that we can support a sort of comprehensive response to sexual and reproductive health in young women in particular. So when thinking about comprehensive sexual and reproductive health responses, some of you may ask, well, what is the potential for a multi-purpose product? And obviously, if we have more data on quarterly dosing, we could potentially do co-administration of 2 products together, like cabotegravir and DMPA. And even with 8-weekly dosing, we can do cabotegravir and NET-N, which is an agent that is used in some countries in sub-Saharan Africa. And then just to say that there is a product that is being developed by Conrad. It is a co-formulated product that contains cabotegravir and levonorgestrel. Levonorgestrel is also a progesterone-based contraceptive, but it's considered a a drug with fewer side effects. And this is in a preclinical development phase, but there's the hope that there may be a first-in-human study in the next few years. So in summary, just to conclude that I think there is a place for long-acting PrEP agents because they can overcome some of the persistence challenges that people experience with taking a daily pill a day, that the initial questions about safety and effectiveness have been addressed, but there are still pending questions in populations of adolescents, pregnant and breastfeeding women, and potentially key populations that may be important to address for future implementation. That the issue of HIV testing approaches is going to be important for cabotegravir, but also for future long-acting systemic agents, and the data coming out of the open label extensions, but also larger scale programs is going to be really important, I think, for providing assurance about the sort of consequences for INSTI resistance. It's really an important signal that WHO has issued guidance that we're seeing regulatory approvals in many sub-Saharan African countries, and that demonstration projects are poised to be implemented this year. The data from those implementation projects will be important for health systems, but actually also important for future manufacturing and access, because we will start to get insights into the coverage estimates and demand. And that will really, I think, help unlock some of the access questions. And then as we move into implementation, it's really important to recognize that we are going to be offering clients choice. And we're going to need job aids and other tools that can support healthcare providers to offer PrEP choice in this kind of ever-expanding PrEP landscape. So thanks very much to these people who contributed slides, and also to acknowledge that this work is the work of many, and really has been an incredible collaboration.